Good morning, everybody. I think you can hear me loud and clear. I think my mic's certainly on. So good morning, and thank you all for coming to this symposium. We're really pleased that you've all made the effort to get out of bed early and come and join us. We have a really exciting program to share with you, and the real emphasis of this symposium is to make you aware of a recent initiative to raise the profile of MPS conditions and to improve time to diagnosis, something that we're all very passionate about to try and address as a priority. So our program really is of some individual speakers, but we'd like you very much to contribute to the symposium. And in your pack, you'll find there's some cards. One is for you to fill in some questions that I'd like to put to the faculty at the end. So as you think of a question, please write them down and hand them in to some of the various people that are going around to collect them as we go along throughout the talks. And we have time at the end to go through those questions. So please do contribute those. And the other thing is to fill in an evaluation form at the end. We very much appreciate your feedback in case you want to do this kind of thing in the future. We may want to do some iterations to the kind of the program. So please fill in the evaluation form, but very much fill in your questions for us for the end. So without any further ado, I'm going to move on to introduce our first speaker, who is do you have the next one? Sorry, excuse us. Yeah, okay, we'll just move on. So yes, our first speaker, who is a very brave young lady, Paige Horton, who's come from Oklahoma, going to tell us her story to really put into context the importance of why we're all here today to try and improve the time to diagnosis. So Paige, thank you very much for coming, and please come to the podium and tell us your story.
Thank you. Hi, I'm Paige Horton, and this is a journey to a diagnosis. So this is a little bit about me for now. I am 13 years old. I have an older brother, Blake, and he's about 20, and 3 dogs, Holly, Abby, and Kara. I enjoy dancing, going to the pool, being outdoors, and just being with my family in general. I love sweets, I'm not gonna lie. Anything, really. I love Marvel Comics, because I'm a bit of a geek. And I got to go on a Make-A-Wish Comic-Con last week. So I have Meritola-May syndrome, or mucopolysaccharidosis, MPS type 6. It all started when I was 4 years old. I was less flexible than my friends in gymnastics and cheer. I had joint issues. Some were too stiff and some were too flexible. And either way, it was very hard to move. So around age 5, I got corneal clouding and a routine eye exam, which didn't make sense. So I was unable to do things that everyone else could do in school, like sitting crisscross. And pain started increasing around then too. I would wake up from numbness and tingling in my hands. So that wasn't very fun. So I had a fast decline in growth charts. I went from being the tallest in my class, so the 90th percentile, down to the 10th. So now I'm shorter than everyone. So we had a bit of a runaround with specialists. So despite finding the corneal clouding, they said there was nothing wrong. So a lot of them said, stop worrying, you don't need a specialist. This is how you're built. Sorry, this isn't my area of expertise, and it's all in your head. So that was very frustrating because you know there's something wrong, but everyone else is saying there isn't, and eventually you start to believe them a little. Thank you. So after 7 frustrating years as specialists, waiting, and disappointments, we finally had an answer. So in 2015 to 2016, we switched pediatricians. The new doctor discovered a heart murmur and referred us to more specialists. We had more waiting and still no answers. So we applied to be seen at Mayo Clinic, mainly due to my mom. She was very persistent and knew there was something there. So in early 2017, we met geneticist Dr. Comboy and Dr. Lamper. So DNA testing was inconclusive. Whole exome sequencing showed a DNA mutation inherited from my dad, but no mutation from my mom. and that made absolutely no sense. So in spring 2017, we met labs geneticist Dr. Vero, who had seen a similar case. He found a second mutation from my mom's genes. So I was diagnosed with mucopolysaccharidosis type 6, or MPS 6. And I'm sure you guys are all very familiar with that. So, and that's an enzyme deficiency in many organs of my body and some joints. So now things are better because we're moving in the right direction. So after a round of false negative tests, my aryl sulfatase, I think I'm pronouncing that right, the enzyme level tests were shown to be 0. I started receiving the appropriate care when I received the correct diagnosis. So I know it's not all in my head. I have a supportive team of doctors who have helped me understand things that I need to do to help my body. And I have family members understand what I'm going through. And we're all on the same page. So at school, staff and classmates are more supportive knowing there is something there, even though they can't see it. My mom and I have a great personal support system, including other families with MPS. So my mission is I want to spread awareness of MPS in the medical field, to the community and with patients. I want to help inform others so that they can get to the right doctors sooner so the disease doesn't progress. And working with different advocacy groups, I want to encourage people to get diagnosed early so they can get the treatment they need. Because even if one person gets diagnosed sooner, or one person gets diagnosed at all, it's very important that it happens. And so you can't help but wonder, if I got diagnosed sooner, would it have progressed as badly? And we don't know the answer for certain. But it's a good thing we got to it where we can, and we can't fix what happened to us, but we can help others. So it's very important that we do that. Thank you for letting me share my story.
Thank you. Thank you, Paige. That was really, really fantastic, and I'm sure we can all identify with many of those steps in Paige's story, the frustrations and challenges faced by you and your family to try and get a right diagnosis. I'm sure there may be some questions around Paige's story, but if you'd like to collate those, and we'll come back to us at the end, we'll have more of a faculty discussion, then I'm sure Paige will answer some questions at the end. So please write them down and pass them on to the... Who's collecting the questions? Yeah, as you wander around. Okay, thank you. Okay, so that's very much putting into context why we're here this morning. And I'm going to very briefly tell you around this initiative that we've been involved with to try and develop some educational tools to try and raise awareness. And then we're going to hear from our other two speakers this morning about 2 case histories that really exemplify some of the challenges as well in terms of diagnostic delay, but also they're exemplars of some of the tools that we can share with you, which hopefully will promote more time for questions. So these are my disclosures, which I have to declare. And as we all are aware, diagnostic delay for MPS conditions is clearly a major problem. And there's a lot of literature out there to tell us that it clearly is a problem across all the various subtypes, some more than others for a variety of reasons. But the median time to diagnosis is about 3 years. But for 20% of patients at least, that's a very, very long time, at least 10 years for a diagnosis to be made, which clearly is very important when there are appropriate treatments available now for many of these conditions. So why do patients experience a delay? Well, clearly the answer is multifactorial, but there's no doubt that the 2 key things that we focused on as part of our initiative are, number one, the lack of clinical awareness, if you like, amongst many of the clinicians out there who will see patients like Paige who present in different ways, and often in quite subtle ways, to make them think about, could this be an MPS condition? So low clinical awareness is one key problem. And the other key problem is either lack of available testing or lack of information about how to interpret the tests and how to pursue a diagnostic pathway. We know that MPS conditions are heterogeneous. Some presentations are very subtle, and the presentations are often very complicated with complex care pathways to specialist care. And children don't present directly to specialists like you. They may present to a family doctor or a pediatrician or another specialist working in a hospital environment. So to tackle these problems, what we've tried to do is to develop some educational tools to try and target the key areas or the clinical areas where increased awareness is needed. And what we've actually done is, I'll just put all of these steps up here, is actually go to the literature and also to do a physician survey to try and identify and describe the pathways of care for many of these children. What were the key symptoms and signs that these children presented with, and also trying to identify the most common of those symptoms and how we can use that to come up with a targeted educational tool to reach the different specialty groups. Much of the information about the literature review and the physician survey has been presented at this meeting, and there's actually a poster presentation, two of the abstracts here, which you can see from Dr. Clark. You can see more information about the survey and the literature review if you want to get more information about how we use this information to make the tools. So the evidence base came from the survey and the literature, and then we went to an international expert group to try and look at that information and to come up with the key diagnostic areas, the key clinicians to target, and what the key messages might be. So this is the international panel, which, as you can see, represents quite a spectrum in terms of specialty areas, so metabolic specialists as well as pediatricians, rheumatologists, orthopedic surgeons, etc., but also from around the world to give a different real-life context to what we're looking at in terms of a clinical problem area. And from this, we've come up with a variety of diagnostic tools, but rather than having an algorithm, which we all know can sometimes be quite complex and sometimes confusing, we decided as a group to keep a diagnostic tool very, very simple, trying to make it pragmatic and to be used in clinical practice more readily, because many of the algorithms that we know are out there are complicated, often a lot of data, decision-making tools, which can be very complex and often aren't used because of their complexity, and that often can be a barrier to them be implemented. So our diagnostic tools, we've kept them simple, and we've developed one per specialty area, and you'll see some examples as part of the two case scenarios after my brief talk. But we've come up with red flag signs and symptoms, often as a constellation or a pattern, which may present to a different specialty area. And hopefully those will be used as red flags to make people think, could this possibly be an MPS condition? And on the slide here, you can just see it's one of the diagnostic tools. This is the one for pediatrics. So it's a single sheet, double-sided, minimal text, but with a picture and key areas of diagnostic issues, and then also on the second page, how to go ahead and get access to diagnostic testing. So the diagnostic testing, this is a site that will soon be made freely available in the public domain, called test4mps.com, and on this site there'll be access to different laboratories around the world. This is one page from the site. So there are over 60 countries listed on the site, with details of how to contact the diagnostic centres, and also information about what diagnostic tests are available in each centre. So hopefully this will be a very, very useful way to help clinicians who have a suspicion, could this child have an MPS condition, to find access to the nearest centre to them and to contact them to get access to the most reliable tests. So what we've tried to do really is to really target the low clinical awareness issue, and also the limitations in laboratory testing issue through this educational initiative. and the series of diagnostic tools will be made freely available once they are published, and at the moment they're going through peer review and editorial review, and this hopefully soon be published by the end of the year, we hope, in a journal, and then the tools will be available through that access and be made freely available to everybody thereafter. So what's your role in all of this? Well, clearly, many of you here are specialists, and you all are here because you have a passionate interest in MPS conditions. And what we're hoping is that once these are freely available, that you will help us and help BioMarion to get these tools out to the various collaborators that you work with, your networking colleagues, to share these tools, to raise awareness amongst the clinical community, to make people aware of the tools and aware of the conditions, and hopefully to use these tools as part of their clinical practice. And ultimately, have more patients diagnosed and more patients diagnosed earlier. And I'm a rheumatologist by trade, and there's a similar problem with children with arthritis in terms of diagnostic delay. And one of my areas of interest for many years is trying to improve access to care for children with suspected arthritis. And one of the things that we have done is develop a website called PMM, and I'm sharing that with you here on this slide. And this website is freely available in the public domain. And this was developed targeting non-specialists, so particularly medical students and family doctors and pediatricians, to try and make them aware of some of the presentations that children with arthritis may have, but also targeting the information in a context that's relevant to them. So for medical students, it's how to pass their exams, but we're putting about a limping child, how to examine joints, etc. And there are key elements of when to think about, could this be arthritis, or could it be an orthopedic problem like Perthes, or a neuromuscular problem like, say, muscular dystrophy. And certainly there's a section in here already about children with a limp, and very much we're going to develop this part of the site to include the diagnostic tools for MPS once they are publicly available. But this is one initiative that's been is a way to get these tools out into the broader community. And PMM has been launched in 2014 and has had hits from all around the world, from students, medical schools and trainees in pediatrics and family doctors. So hopefully we're targeting the right audience by its dissemination. Hopefully using this will help us also disseminate the MPS tools. So please have a look at the website and see what you think. And then sure enough, the tools will be on there in due course. So I'm going to finish my presentation there, and again I'm happy to take any questions relevant to my presentation at the end, so please jot them down and share them with us later on. But I'm going to pass over now to our two other speakers who are going to share with us two case scenarios to really highlight the spectrum of MPS and some of the diagnostic challenges, and also share with you two of the diagnostic tools as exemplars of the overall package from the educational initiative. I'd introduce first of all, who's going first? Daphne? Yeah. Dr. Horowitz from Brazil, who's going to share a case with us, and look forward to her talk.
Is this on? Yeah. Okay. Thank you. So good morning, everyone, and thank you for coming so early for Breakfast Symposium. I have an interesting case to present. It's actually a typical MPS 6 case, but the way it presented and the way it was diagnosed was very peculiar to all of us. So these are my disclosures. It's a little boy. He's now 8 years old. We started following him around 2 years old. So he was born in 2010. Second child of a non-consanguineous couple. The mother has a total of 4 children, 2 other children from a previous marriage. Pregnancy was fine, and it was a C-section at 36 weeks, 6 days. So he was not exactly at term, a little bit before, but a huge baby. He weighed almost 5 kilos, 55 centimeters. Head circumference was okay for his size. and he was discharged home at 3 days. Hearing screening, newborn hearing screening was not normal, and the mother was told to come back a while later to be retested. Then he started having problems. So this is the baby, and he was really very big, and if we look back, he looks a little too big, and maybe we can say there is a little bit of an edema, maybe he had a little bit of hydrops, but nobody wrote any notes about this at the time. Well, when he was 23 days old, he presented cyanosis and had a cardiopulmonary arrest, was in the ICU for 10 days, and he also had a seizure due to the time he stayed on arrest. Then, right on hospital admission, they saw mitral insufficiency. This is extremely rare for a newborn, and he was diagnosed with a congenital mitral insufficiency. During the first year, his first year was extremely complicated. He was in and out of hospital admissions. He was in the ICU for quite a while, had 3 cardiopulmonary arrests altogether, and he was using a lot of medicine for his heart. And finally, and he developed, so it was the mitral insufficiency, and then it evolved to a cardiomyopathy. Then it was indicated heart surgery, and he had heart surgery at 13 months of age. So he was referred to a metabolic specialist. Actually, the first time something was said about a metabolic specialist was by the heart surgeon. This is our single referral by a heart surgeon. We never had something like that. They come for multiple reasons, but never like that. So in the post-surgical echocardiogram, there were still a little dilation of the left chambers, mitral regurgitation, a little bit of dysfunction, but he was already much better. The surgeon said, this valve is clearly abnormal. It has storage. He has to be seen by a metabolic specialist. And then he was sent to the metabolic unit. He lives about 4 hours away from Rio de Janeiro. So it took a while for him to be operated, to stay in hospital, to recover, go back to his original city, and then come to us. And he finally came when he was 19 months old. So looking at him, we could tell the diagnosis. And it's amazing that nobody thought of this before. I mean, he was being seen by pediatricians and neonatal intensive care for a while. For his whole first year, nobody saw anything. So he had already coarse fascias, hernia, joint restriction, claw hand, the whole picture of MPS. His x-rays clearly show dysostosis multiplex. And most amazingly, his chest x-ray is very typical of storage. He has the OR-shaped pedal ribs, and I am sure that with that many pneumonias and with the heart problem, he had several chest x-rays. But they were looking at something else for sure. They were looking at his lungs, they were looking at his heart. Nobody spotted the ribs for some reason. Well, he was evaluated for MPS. He had very high levels of urinary gags and low enzyme activity. We confirmed MPS 6, and the disease-specific management started at 28 months because it took a while. But in the cardiological follow-up, he's doing great. No drugs at this point. He has still a thickened mitral valve, but it has been corrected. His sleep studies were clearly abnormal. They returned to normal. He has some hearing deficit, but now he is a very typical MPS 6 boy. So to summarize his timeline, so it all started at birth, and I think birth is very important, his birth weight. The children that big, it can happen, but we have to watch out because there may be something else. And MPS, it's more typical that we see those big babies, big children in the beginning, and then in the growth curve, they go from 98 to fifth percentile or maybe even below, like Paige said, happened to her. Then he had the cardiopulmonary arrest, ICU, within 1 year, multiple admissions, pneumonias, cardiopulmonary arrest, but a very specific and rare disease, the mitral valve insufficiency. He was diagnosed with congenital mitral valve insufficiency. Then at 19 months, very typical MPS, MPS 6 diagnosis, and then he keeps now in follow-up and specific management. So if we look at the two, it's very obvious if we see the cardiac two. So cardiac valve thickening is very important, especially if the child is that young, and I'll show you later, right in the next slide, the two. But there is a list of signs and symptoms, so this should prompt investigation for MPS. Left ventricular hypertrophy, we know we can see in other diseases, but in other storage diseases as well. They have to be investigated. And then all the rest, coarse facial features, developmental delay. So if we have those features, and especially if we have a combination of features, we have to think about MPS and considering order in enzyme panel. So this is the two, and this is the two for cardiology. Cardiac valvular thickening, consider MPS. And we have below 1 year of age, next steps, screen for MPS, pure and simple. So cardiac valve thickening is very rare so early. If it's over 1 year of age, of course, we have to consider other things or combination of clinical features. So this is about it. I think we can answer questions later, but thank you so much for being here so early. This is our hospital in Rio, right in front of Sugarloaf, so you're welcome to visit anytime. Thank you.
Thank you, Daphne. That was an excellent presentation, and I think that really highlights a really nice example of the tool that can be used perhaps for the cardiology context, but that little boy's case, and a lot of similarities with Paige's case as well about frustrations in terms of it took a while for things to come together. So we're going to hear now from Dr. Clayne White, who's an orthopedic surgeon from Seattle, and he's going to tell us about a different case scenario with some of the more subtle presentation of MPS, and again share with us with one of the tools. Thank you. Thank you, Clayne.
Thanks, Helen. Good morning. Great turnout for a 7 a.m. symposium. I feel like Steve Jobs up here with no podium. So I'm going to be discussing a non-classical MPS 4 patient, and in the end, I think this scenario is going to highlight the value of these tools, which is, I think, the primary takeaway message from this morning's symposium. And I have disclosures. This young boy was born in 2000 and had a very typical early childhood, a little speech therapy, but otherwise was bright and active and no other notable issues, and had very no significant family medical issues. His mother wears glasses for being nearsighted, which you would consider in a workup for a skeletal dysplasia, which is my life, for type 2 collagen disorder. But really, I mean, his parents are, as you would expect, very typical. But Scott's story started when he was 4 years of age and started having some aches and pains in his legs. And we see this a lot in young children, and we tell the parents, don't worry about it, and we quote unquote call it growing pains. But his was persistent, and by age 7, 2 or 3 years later, he had an X-ray of his hips, which showed findings consistent with Perthes disease. And this was in our orthopedic clinic in Seattle, and so he was told he had bilateral Perthes. Kind of went on. There was nothing to do about it. We just watch it. Otherwise, he had no other signs of MPS, no joint stiffness, no swelling in his joints, no obvious deformities. Maybe he was a little on the short side, but his parents aren't terribly tall, but he wasn't off the chart by any means. And these were his x-rays, and if I show you nothing else today, it's this x-ray. If you see, if you look, you don't have to look too carefully, but you see these changes where it looks like someone just took a little bite out of the femoral head. And I will tell you that this is not typical of bilateral perthes. This is typical of a storage disorder. But oftentimes in orthopedics clinics and by radiologists, good pediatric radiologists will call this Perthes disease. So this is where he was at age 7. So he went on being watched, and we started developing some increasing awareness of the significance of these x-rays. And so he was referred to our skeletal dysplasia clinic at age 9. And so like good genetics clinic, we sent our urine MPS labs, and well, they were normal. And so, well, he doesn't have MPS because his labs are normal, his urine's normal. And I would venture to guess that Paige probably had a very similar workup and result. And again, Scott was active. He was playing soccer, hockey. You can see him here. This is not a physically limited child. And developmentally, totally normal, very bright young man. And you can see here, this is not a child who has any limitations in activity. And again, he's still a little on the short side. Maybe if you look at his arm span, it's a little bit longer, so you could say perhaps this would be a sign of a slightly short trunk. But again, no signs of type 2 collagen disorders, no signs of spine or hip deformities, and so forth. So, but he was back in our skeletal dysplasia clinic, and we decided to get a skeletal survey at this point. And I think what we point out here is not only do we know about the hip disease, but when you look at his spine, he's got platyspondyly, he's got an underdeveloped vertebral body here. And it's a little subtle on this x-ray, but it's definitely there. And if you look at his feet, and if you look at his hands, there's some coarseness to some of the metacarpal, metatarsal bones and so forth. So, I'm sorry, here's his skull film, totally normal skull film. No signs of dysostosis multiplex in the cervical spine. No sign. He has a totally normal sella turcica here. So, doesn't look like MPS, but we were persistent. We sent it again, and guess what? It was still normal. And so, okay, well, it's not MPS, so what else are we going to look for? Well, in the differential, there's going to be your type 2 collagen disorders, Stickler, other forms of spondylopiphyseal dysplasia, and other skeletal dysplasias that have spinal involvement and hip involvement. And, of course, they were negative. And this was about 10 years ago, so this was pre-exome sequencing. So that's where we were. And, he came back again in another year, and we just kind of kept following him because we couldn't really figure this out. It just didn't make sense. Something was different about Scott. And so in the meantime, he's starting to develop a little bit more pectus carinatum, and so we had just had another patient who had been diagnosed with spondylopiphyseal dysplasia for 10 years, and she had had normal urine tests as well. And so we sent enzyme testing on her, and lo and behold, she had Morchio. And so for Scott, we said, okay, well, let's go ahead and send his enzyme testing. And surprise, surprise, it was abnormally low. And we did mutation analysis, followed up. He had one known mutation. The other one, we never found a second mutation. And so clearly his diagnosis was Morchio, type A. So I think a couple of learning points here is that non-classical Morchio patients can be normal statured. They're not your classical short-statured Morchio patients. They can fall off the growth curve late, but Scott never really did. In fact, he had a bit of an adolescent growth spurt, which I'll show you. But progressive hip, spine, and chest wall deformities, and I don't go into this because this is all about diagnosis, but Scott ended up developing pretty severe kyphoscoliosis. He had it required surgery later in life. And again, in case it's not clear, the urine gags are often normal. And this is Scott's growth curve. So this is not what if you look at Adriano Montagno's papers with, the spectrum of growth, this is not Scott. Scott was on the normal growth curve throughout. So much like Daphne had a timeline, this is Scott's timeline. His birth and young childhood was relatively unnormal, but he started showing signs and symptoms at age 4. And at age 7 was inappropriately diagnosed with Perthes disease, and not until age 10 was he diagnosed. So in a center where we pride ourselves on having a pretty good skeletal dysplasia program, it took him 6 years to be diagnosed. So this is, so some people say, well, that wouldn't happen in my center. Well, it did, and it does. So, so the challenges, again, are bilateral Perthes often is people stop there. If you look, and Lauren Clark will make this point, if you do a skeletal dysplasia exome slice, or any of the commercially available diagnostic skeletal dysplasia studies for mutation analysis, almost none of them, I don't think any of them include Morquio syndrome in that, so be aware of that. And if you are really convinced that there's something different, just send enzyme, because that's what's going to give you the answer. And so this is the algorithm we use. This is from Tim Wood. But you can do urine screening and so forth, but really, if you want to know the answer, go straight to enzyme analysis, and then you can confirm it with molecular analysis. And as far as our tool goes, I think what we developed is simply, and Scott's case highlights this so well, is that vertebral body abnormalities, particularly a hypoplastic vertebral body, or the presence of hip osteonecrosis, particularly bilateral hip osteonecrosis that looks the same on both sides, Perthes-like changes, should be considered an indication for testing for MPS. And so this is the orthopedic diagnostic tool which has been developed, and I think we'll be distributing hopefully by the end of the year. And I think there are some sample x-rays here, and this is a very similar x-ray to Scott's, where you see this little, I know it's hard to see from where you are, but a little bite out of the femoral head. And again, so if there are older kids, you can do the testing for urine, but again, you should probably refer them to a geneticist, or at the very least, and I'm encouraging orthopedic surgeons, just go ahead and send the enzyme test. It's free and it's easy. So, and you don't have to, once you get the answer, then send them to the geneticist, because it takes 6 months to get them into the genetics clinic anyway. So, appreciate your time, and we'll, I think, open up the floor for questions.
That was excellent. And again, very nice example of a presentation highlighting some of the challenges and problems in diagnosis and showing you the orthopedic tool. So now we're going to have some time for questions. We're very happy to take questions. So we've got some here at the front, but if you have any more questions, please either hand them in, or you can come to the microphone if you're feeling brave. By all means, come to the microphone, tell us who you are, where you're from, and present your question. So please.
Hello, I'm Carolina from Brazil, Porto Alegre, south of Brazil, medical geneticist. My question is to Dr. Klein about the screening test for MPS patients. What do you use normally? Only the quantification of GAGs, or also the electrophoresis? Because we know for Morquio diseases, most cases can be normal. The quantification was example.
No, we do both quantitative and qualitative GAGs with electrophoresis, and I think it's pretty clear that older children, both with MPS 6 and MPS 4, who have what we consider an attenuated presentation, urine GAGs are almost universally normal. But it doesn't really matter if you do quantitative or qualitative.
Yeah. And for these cases, do you have measure the GAGs electrophoresis or not? Because you show only the quantification analysis.
Yeah, I didn't present it, but I'm sure we had it.
Okay, thank you.
Thank you. There's another question from the floor. Please come forward.
Michael Beck from the University of Mainz. I would like to make a general comment on the delay of diagnosis. That's true not only for mucopolysaccharidosis, but for all lysosomal storage disorders. And in my long time experience, I saw several cases where the diagnosis was not done by the doctor, but the parents and the patients, because they went to Google. And there are many, many examples. I have 3 or 4 examples where the diagnosis has been done by the parents. They gave the symptoms and made the diagnosis, for example, Gaucher-Fabry disease, Niemann-Pick type C disease, and so on. And I also expect from the physicians that when there's some unusual case, corneal clouding and stiffness, as you have described, then they should go to Google and look what they can see. And I'm interested, and I will do it thereafter immediately. Google corneal clouding and joint stiffness. You may find the diagnosis, I don't know. And in another case, we have also made very good experience with rheumatologists in Germany. They have done the diagnosis in many, many cases, also unusual cases, because I think they have time or they have more experience. I don't know. And I agree with you that you can make often the diagnosis of all lysosomal storage disorders. Thank you very much.
Okay. Thank you for those comments. I think as you mentioned, it's often the pattern of things that occur together that we want people to start thinking a little bit outside the box of clouding, joint stiffness, history of a hernia, for example. Just think about these things, and that's the challenge that we face, really. With regard to your comment about parents, it's often the parents that make the diagnosis. I wonder if any parents would like to make a comment on that, about, because there is actually a question that's come to us. Oh, sorry, Clay.
I can. Well, I don't know if everyone knows, but I had a daughter who had Hurler syndrome, and so she had a kyphosis, and there's very few things that can cause kyphosis. And I was a resident at the time, and this was pre-Google, and so I got out my pediatric textbook to find out what causes kyphosis, and it's either a skeletal dysplasia such as achondroplasia, or and in this book it was Hurler syndrome or Morchio. And this was 1999, okay? And so we went to see the geneticist, who said, your kid's fine. She was 6 months of age. There's no problem here. And so we were persistent about it. And he said, well, we can send testing now, or we can send it in a year, or whatever. And so we said, no, we'll send it now. And it turned out it was fortuitous, because she had Hurler syndrome, and bone marrow transplant at a young age is extremely critical. And so, and we were here in San Diego at the time. The geneticist is very well known. Actually, has a textbook that he's the editor for. And so, this is not a situation that's unique to third world countries, or someone who lives in the middle of nowhere in the United States or whatever. This is in major metropolitan centers. So, and I guess my question for Paige is: did you see an ophthalmologist or an optometrist who noticed the clouding? Was it an eyeglass doctor, or was it like a real medical doctor?
So we actually went to multiple doctors. So we had one that was just a routine one, but then they sent us to Dr. Kozlowski, I think I'm saying her name right, down in Oklahoma City. And she does pediatrics. So that's how we kind of figured that out. I'm not sure exactly which one she is. I think my mom would know.
Yeah, I think the point there is that it's parents being very persistent, and it takes quite a brave parent to often go against what they've been told, and so it's an empowered parent is often required just to keep being persistent. So, is Paige's mum?
Hi, I'm Belinda. I'm Paige's mom. And in answer to that question, we went to an ophthalmologist and actually was referred to as corneal specialist as well. The way the corneal clouding presented was subtle. I mentioned the idea of genetic storage disorder, and I actually did this with rheumatologists, neurologists, orthopedics, everywhere we had been. For some reason in our area, again, this is not well known as it is in most, but again, it kept getting denied. And no, this isn't my area, and they'd pass this off to somebody else. The doctor is the gateway to those testings. And unless we can get them convinced and get them up to speed on the knowledge and what to look for, oftentimes they're not listening to the parents as well. So it was at that point, after we had all of these doctors we had been to, who, in hindsight, if I had known even more than I know now, I would have pushed even harder. again, they were the gateway to get somewhere else. We finally just said enough's enough. We're going to go to Mayo Clinic, and it takes that leap. Sometimes you have to just sidestep what you're being told. But yes, we had even went to a corneal specialist at that point. And again, it was not pushed through. And as you said, Dr. White, the geneticist takes 6 months to get into. And again, those referrals weren't being remade, even though we'd been to a geneticist before.
Yeah. No, thank you. And in fact, two of the comments that have come from the floor is one about, is there going to be some kind of diagnostic tool for parents? So maybe that's a comment for Biomarin to think about. Is there going to be a tool for parents? That's come from the floor. And the second thing is there going to be a tool for ophthalmologists and optometrists to think about targeting that group to raise awareness? That's come from the floor. So that's for us to think about. Another question?
Not a question. You had mentioned wanting to know about some ways people were diagnosed. We actually had somebody approach us in the mall with our 15-month-old and say that he had some characteristics of her brother who had died of Hunter syndrome. And as a result of that, we asked our pediatrician, and it turned out our son had Hurlers, and we got diagnosed at 16 months and just in time to get the transplant. So just somebody approaching us at the mall, noticing characteristics that none of our doctors had noticed. And looking back, we can pinpoint some of the traits that he had, the umbilical hernia, the big head, things like that, but nobody had noticed that, and it wasn't enough of a concern that we had because he seemed to be developing correctly. But just a random meeting of a stranger in the mall was kind of how we got our diagnosis a year ago.
So quite fortuitous in a way, but and I guess it's having seen one case, rare as it can be, is often a great trigger for clinicians to think, could this be another case? And I guess having seen one helps to raise awareness for other people. But in your case, obviously that was quite a fortuitous meeting in the mall. So thank you for sharing that.
My name is Xiang Yulin. I come from Mackay Memorial Hospital in Taiwan. I have a question for Dr. Klein White. Thank you for your very nice presentation. I'm a pediatrician and a medical geneticist. In a clinical point of view, it is difficult for us to early diagnosis for an attenuated patient with MPS 4A. I wonder, are these attenuated MPS 4A compared to the typical case of MPS 4A? Do their enzyme activity have any difference? Enzyme activity.
Okay, he asked me to answer. The enzyme activity would be the same. So the whole point is, think about the diagnosis and order the enzyme activities. If you stick to urinary gags, especially in morchio, is those milder cases, so it's keratin that they excrete, and sometimes they can be normal. So I would go through enzyme activity. And this would be, I mean, it's very important for us to have the molecular diagnosis as well, but you can diagnose, confirm, go to specific treatment just with enzyme studies. And actually that was a question for Paige as well, but because it seems that it took so long, and she went through exome sequencing, and then she did the enzyme study. She had some urine tests that now her mom thinks it was, they were looking for gags. But whoever was thinking about that should have gone one step further, and they would have diagnosed before the exome sequencing.
Yeah, in our lab also performed the quantitative of dermatoin sulfate, heparin sulfate, keratin sulfate by tandem mass quantification. And in our lab experience, it is true that it's usually a false negative result by DMB method for urine gag, especially for MPS 4A, MPS 4. And I wonder, in your case, do you perform the quantitative of KS, keratin sulfate, for this attenuated MPS 4A? I wonder, are there any difference for typical case of MPS 4A for their KS, keratin sulfate, with specific KS?
I think they performed all the tests and they were really negative.
Oh, really negative.
Yeah, and it can happen. It can happen with molecules, so we really have to be aware of that.
Yeah, thank you so much.
You're welcome.
Thank you.
Hi, my name is Mary Kavanaugh, and I have a question and a comment. And first of all, I want to say thank you, my heartfelt thanks to Dr. White. He's our doctor in Seattle, and Scott is my son. And I wanted to back up a little bit because I have a question. And we're originally from Canada, in Ontario, where seeing a pediatrician is not the norm for children with universal health care there. So it starts with a family doctor that sees our whole entire family. And at about probably age 3, I started mentioning the limp to that family doctor, and he had an extended abdomen as well at that time. And I think over the course of a couple years, we had 2 different family doctors, and they both said nothing's wrong, stop worrying, look at him walk down the hall, he's absolutely fine. And I said, well, yes, but he doesn't limp 100% of the time. And in Canada, if you don't have a referral to a specialist, you have no hopes of seeing one. You can't just call and make an appointment yourself. So I was at a roadblock there. But there wasn't enough signs and symptoms for me to be very, very concerned, so I was just happy that the family doctor said he was fine. So, and then if I fast forward to age 6, that's when we moved to the Seattle area. So my question is, how can you go about getting all this information across the world to the numerous family doctors out there and pediatricians?
Yeah, I think you're absolutely right that many parts of the world, certainly in the UK, the patient access to specialist care comes through the family doctor. And obviously family doctors see lots of children with lots of problems or lots of potential problems, and sifting out or filtering out these patients is a great challenge. And I think the response is that it is challenging, but maybe it's a combination of maybe going to the health visitor, because some of the key points on the family medicine chart or the tool is looking at the pattern of things like, you know, developmental delay or growth patterns or other features. And so it'll be a case of drip educational feeding to some of the family doctors. But I think it is going to be a challenge, because they're going to say, well, these conditions are so rare, they may never see one in their lifetime of practice. But we have to try and do what we can to try and target them.
Yeah, when I look back at his history now, we had a family doctor who retired, and then we went to a new family doctor, and it was in that gap where he went from 50th percentile of height down to 5th percentile, and it was lost because they didn't look back at the old growth charts, I believe. And then my other comment was, Dr. White said, you know, it can happen anywhere. It happened in our clinic. Well, we also took Scott to Cedars-Sinai in LA, so it happened there as well. He couldn't be diagnosed. So I just wanted to point that out.
Yeah, thank you.
Thank you.
Thank you. Thank you for sharing that. And I think, you know, back to parents being empowered, and parents having the persistence to keep looking, keep chasing for a diagnosis, as we're hearing that recurring as a problem, or here as a key feature for the diagnostic pathway. One more question. Okay. I think we're running out of time, guys, so if you a quick question.
It's just a quick comment about actually what she was saying. My name is Kara, and I'm a lysosomal nurse program coordinator at Phoenix Children's Hospital in Arizona. And our geneticist has taken it upon to go out and do education in the community. So she speaks at a lot of the pediatric conferences and a lot of the conferences that have physicians there that aren't geneticists, to get the word out. And they actually told her the topic of her talk was early diagnosis of MPS, or I think it was something like, these kids are in your practice. And they told her that she didn't need to do it, and she said, no, they are out there. And we actually came up with a program that these physicians can contact us, either our physician or me or our program, and we actually will do the free testing And I bring them in, I test them, I send it out, the enzyme, for anybody that they think that MPS or we have free testing in other lysosomal storage diseases, because just like every geneticist, our wait is probably more than 6 months, but we will get them in within a week or two if we suspect it or if the testing's positive. So it's a way to get around getting that testing done, get them into the practice, and get them diagnosed. So I encourage everyone geneticists out there to get out there and do the education yourself in your own community and reach those physicians that are really seeing these patients in the community.
Thank you for sharing that. Thank you. Okay, well, thank you very much. I think we have run out of time. It's time to move on with the rest of the program for the rest of the day. So thank you very much for coming, for your contributions and the questions that we haven't actually used, we will pass on to the faculty as well. But please do fill in your evaluation form for this morning. We very much appreciate your feedback and comments. So fill them in and leave them on the chair or hand them in on your way out. We'll be very grateful. And lastly, thank you to our speaker, particularly Paige, for having the courage to come and tell us about her story. So thank you. Thank you very much.